And now we'll move on to the last presentation in this session. Dr. Senthil would be speaking. I don't know what he will cover. All laparoscopic robotic are open, or is only one? So you have to clarify this. Okay, please.
Sir, I'll do both lab as well as robotic, skip open in the interest of time. So we all know the ramps, anterior, posterior 1 and posterior 2. I'll go straight to the video. I'll be showing 3 videos, one anterior ramps, then posterior, and then the robotic approach. Yeah. The first step is opening the gastrocolic omentum, gaining access to the lesser sac. Expose the pancreas fully so that we'll know where exactly the parenchymal transection can be. First, the dissection starts from the inferior border of the pancreas. Always it's easy, it's accessible. We are looking from below, so it's better that we look at from the inferior border of the pancreas. Start mobilizing from inferior on to the posterior aspect. Here you can see it's a large tumor going on to the infracolic, dividing the mesentery and then gaining into the closing. We are going close to the DJ flexure. A lot of times, DJ flexure is infiltration of the DJ flexure is a rate limiting step. So we need to understand, mobilize the DJ flexure away, mobilize the colon away, so that we are not dealing with the multivisceral resection. So once we have done that one, mobilizing it onto the entire inferior border of pancreas, putting all the colon splenic flexure as well as the DJ flexure away. It's very important to find out the extent of the resection. So once the mobilization is done, we again come to the superior aspect, see what's, this is the nodal, this celiac axis clearance. Nodes are harvested. You can see the pulsating splenic artery. As you can see here, the splenic artery is going into the tumor and coming out. The splenic artery is involved by the tumor. So we have to get the proximal control. And that's the left gastric. So we are going into the root of the celiac axis and then dissecting the that area so that we have a nice proximal control. We can use hemolock or stitch, the good old method. Here this is ligation in continuity. We will not divide the splenic artery, but we have a control. So splenic artery is done. Then we come to the inferior aspect, lift up the pancreas at the line of transection. Here you can see the splenic vein coming into our view. These are very crucial steps before we go to the removal of the pancreas along with the fascia. Sometimes we use endomini tract. Very many ways of dealing with the pancreatic stump. In this particular case, we have used, we have divided the pancreas with the harmonic scalpel and then sutured the stump. It's a soft pancreas, as you can see. So once the pancreas, sometimes you will have the transverse pancreatic branches also that has to be coagulated and divided. So now this is very close, very proximally we are dividing it. Next, the splenic, once we divide the pancreas, transect the pancreas, we have the artery and as well as the vein coming into picture. So dissecting and then putting additional clips and managing the splenic artery becomes easy. Then we come to the splenic vein. So again, this is the inferior mesenteric vein coming down below. You can see this is the inferior mesenteric vein. So we are dividing the splenic vein close to the splenoportal confluence, making sure that the inferior mesenteric is draining into the proximal stump. That's very important. So once that is done, this is the anterior rams we remove along with the fascia, and then we remove the specimen after along with the spleen. So that is the laparoscopic rams. Next video, I am going to skip the initial portion in the interest of time, because this is a posterior rams. Tumor is involving posterior capsule. Again, through if you make a big window, we can always have a nice access to the splenic artery. If the tumor is bulk and you cannot reach the from the superior aspect of the pancreas. There are very many ways of dealing with that one. This is one way. You can see the splenic artery is divided, clipped from below because of wider mobilization of the pancreas. You can see now the splenic artery, it's coming up superiorly, but from below also we can tackle it once you mobilize the neck completely away from the pancreas, away from the posterior attachments. Once we divide that, you do the lymphadenectomy in the celiac axis as well as the splenic artery area. This is a slightly bigger tumor which adherent to the posterior capsule. This is the lymphadenectomy part. Splenic artery is divided. So now we have a bigger mobilized pancreas. In this case, we have used the stapler. As you can see, wider neck, wider mobilization. Staple is divided, hard pancreas. So now the posterior rams starts from this, from proximally, from retrograde fashion. We do posterior dissection, including the adrenal. This is a rams, posterior rams type 1. So here we have to be very careful in identifying the plane. Gyrotous fascia is out, the adrenal is out, so that we maintain the proper oncological plane. Here you can see the cuff of the gyrotous fascia being onto the capsule, onto the specimen. In rams, posterior rams 2, we also remove the kidney as a part of the procedure, but here you can see the capsule is taken along with the specimen. That's why it's posterior rams type 1. And here you can see the kidney, and on medial to the kidney we have the adrenal that will be removed shortly also. So in the interest of time, I will skip it. It's completely mobilized. And here, like in the splenic artery, once we remove the entire specimen, we have big vision posteriorly, so that the posterior rams can be completed in a very nice fashion. I'll show here. So once the entire specimen is complete, we will go to the adrenal. The adrenal is slowly mobilized. Again, the adrenal vein and the artery it has to be very carefully identified, clipped. Rather than allow it to bleed, it has to be clipped and divided. The dirty yellow looking adrenal along with the vasculature. So that we bear all. This is a ram, and then the kidney surface, the retroperitoneal structures are seen clearly. So this is the entire left adrenal gland is lifted up, clipped, vein is clipped last, which drains into the renal vein, and then we divide the final bit of attachments, so that the entire lymphatic tissues as well as the surrounding the adrenal is removed, as you can see. We use multiple energy sources, including ligature as well as the harmonic scalpel, to make this happen without much of a blood loss. I think, then this is the final bit. You can see that's being removed. And that's the bed after doing the posterior ramps type 1. So I'll have a minute left for my robotic. Robotic, again, for the starters in HPB surgery, distal pancreatectomy is one of the very nice procedures. Select small tumors, later we can do. What we have done is, we have custom made some technique like retracting the stomach, because we don't have much instruments and we don't want to crowd the that particular operative area with lot of instruments. So stomach is hooked to the anterior abdominal wall. That frees us a lot of space, and you can have a hands-free or a completely instrument-free approach to the particular area. Again, like in the previous video, mobilizing from below. Very important, you can see this is again the adenocarcinoma. So I'll run down the video. So inferiorly, we have to mobilize, gain access to the superior aspect. This is creating the inferior, lifting the pancreas away from the vessels. And then once we have done, we go to the superior aspect, do the splenic artery dissection as well as lymphadenectomy at the superior border of pancreas. We can use scissors, fenestrated forceps, bipolar forceps, depending on the personal preference. Artery is hooked, lymphadenectomy is done, and then we suture. Whether it's in laparoscopy or in robotic surgery, at least one suture we try to place in at the artery site. So once that is done, we again come to the inferior aspect, try to dissect the pancreas still away from the posterior attachments, and then staple is done. Mostly for robotic we use stapler, and then the rest of the procedure. And here, more than the laparoscopy, we use lot of such retracting stitches, so that we have a nice counter traction for the robotic arms to be working nicely. So I think these are the posterior retroperitoneal, the veins. Sorry. The vein, the splenic vein is clipped. It's a small caliber, so we need there was no need for a staple. If it's a large one, we can put stapler. Otherwise, hemolock is quite okay. If the veins caliber is can be occluded with the vein, hemolock. So and then we remove. It's an anterior type. We remove it, and then we remove it in the specimen back.
Thank you.
Thank you very much, sir.